Good morning, this is Dr. Vishal from Department of Conservative Dentistry and Endodontics, Malareddy Institute of Dental Sciences. Today I am going to take a lecture on pulp protection. What is the importance of pulp protection? Pulp protection should be done to maintain the vitality of the tooth. There are several irritants that causes the pulpal inflammation. These are the several irritants which causes the pulpal irritation, such as bacterial irritants, traumatic injuries and iatrogenic injuries or idiopathic causes. Coming to the most common causes, the first one is bacterial irritants. This is the one of the most common cause for the pulpal irritation. The first cause is dental caries. First, the dental caries invades the enamel and it invades into the dentin and causes the pulpal irritation. The second most important cause is your periodontal pocket or abscess. And the next one is traumatic causes, and the traumatic causes are acute trauma or idiopathic injuries or due to the avulsion of the tooth due to the traffic accidents or the collisions. And the next one is chronic trauma from the parafunctional habits like bruxism. Coming to the iatrogenic causes, the first cause is the heat generated during the cavity preparation. Whenever you are doing the cavity preparation, if there is excess generation of the heat due to improper use of the coolant, there may be chances of pulpal irritation. So, if the pulpal temperature is increased by more than 11 degrees centigrade, there is 100% chance of the pulpal inflammation due to the heat that is produced during the cavity preparation. So, pulpal temperature is critical and must not exceed normal values in the dental restorative procedures. If the pulpal temperature is increased by 5.5 degrees centigrade, there is a chance of 60% damage to the pulp, whereas if it is exceeds to the 11 degrees centigrade, there is 100% chance of the pulpal irritation. So, this picture depicts the pulpal damage due to the heat. Whenever there is a excess heat produced during the cavity preparation, this is the tooth preparation. There is avascular changes in the tooth causing the internal hemorrhage, causing the irreversible damage to the tooth. The next one is the pressure that is exerted due to the during the cavity preparation. If you use the blunt instruments or not sharp instruments during the cavity preparation, there is excess amount of the pressure that is exerted into the cavity, which causes the irreversible damage to the pulp. So, the pressure exerted by the hand or rotary instruments causes the nuclear aspiration of the odontoblasts or nerve endings from the pulpal tissues into the dental tubules, which causes the disturbance in the odontoblast metabolism, causing the pulpal damage. And the next one is remaining dentin thickness. Lesser the remaining dentin thickness, more the chances of pulpal irritation. If the remaining dentin thickness is more, there is less chance of pulpal irritation. So, what is remaining dentin thickness? It is the distance between the floor of the cavity to the pulp. And the next cause is orthodontic movement. Whenever the patient is undergoing the orthodontic movement, there is chance of pulpal irritation due to the damage to the periodontal cells, and also periodontal curettage or periapical curettage can also causes the pulpal irritation. These are the iatrogenic causes. And also the various use of chemicals like fillings, bases, liners and use of alcohol leads to the pulpal injuries due to its cytotoxicity. Cytotoxicity means cell death, which causes the cell death, acidity, heat formed and marginal leakage. And coming to the next cause, that is idiopathic cause. Idiopathic causes are mainly due to the aging of the patient. In old age patient, generally resorption can be seen, which causes the pulpal irritation. Generally resorption can be classified into two types, that is internal resorption and external resorption. So, because of all these irritants, it is important to protect the pulp from the above mentioned irritants. So, coming to the pulp protection, generally the cavities are classified based on their depth. If the cavity is shallow, there is no need of pulpal protection. But if the cavity is moderately deep or complete destruction, there will be more chances of pulpal irritation. So, we need to protect the pulp. Coming to the moderate carious lesions, that is where the caries penetrate the enamel and dentin, but not to an extent of endangering the pulp. So, in this, remaining dentin thickness will be less but not endangering the pulp. Whereas in the deep carious lesions, caries are very near to the pulp, which causes the pulpal irritation. Whereas in moderate carious lesions, first we have to apply a liner and followed by the subbase and the restoration to protect the pulp from the irritants. Whereas in the deep carious lesions, you should always protect the pulp by various techniques such as conventional methods like indirect pulp capping and direct pulp capping, and recent methods like laser pulp capping and calcium hydroxide pulpotomy. What is pulpotomy? It is the technique which the kernel pulp is extirpated and over the medicament is placed to protect the radicular pulp. Coming to the conventional methods, the first one is direct pulp capping. In direct pulp capping, during the cavity preparation, there may be chances of iatrogenic exposure of the pulp due to the cavity preparation, or sometimes there is carious exposure of the pulp. In such cases, we will do the direct pulp capping. So, in the direct pulp capping, the medicament is directly placed onto the exposed pulp, and it is done to maintain the vitality of the pulp and to promote the pulpal healing, thereby vitality of the tooth is maintained. So why we have to do the direct pulp capping? First one is to maintain the vitality of the remaining pulpal tissue and to prevent the root canal treatment, and also to help the conservation of the tooth structure. So what are the indications of direct pulp capping? We should always do the direct pulp capping only when there is small mechanical exposure less than 24 hours during the tooth preparation or traumatic injuries. Whenever there is the carious exposure of the tooth, you should not attempt the direct pulp capping. And the next one is no or minimal bleeding at the exposure site. So bleeding should be minimal or no at the site of exposure to carry out the direct pulp capping. If there is uncontrolled bleeding, you should not attempt the direct pulp capping. So coming to the contraindications, we have seen the indications. Coming to the contraindications, the first one is, first and foremost is, if there is any wide pulpal exposure, and that too if there is carious exposure, you should not attempt the direct pulp capping. And also if there is uncontrolled bleedings from the cavity, we should not do the direct pulp capping. And if the patient is having any preoperative symptoms of pain, we should never attempt direct pulp capping, and there is evidence of radiographic pathology, we should not attempt the direct pulp capping. Coming to the clinical procedure of the direct pulp capping, first the local anesthesia is administered to the patient, and the tooth to be operated is isolated with the rubber dam, followed by the excavation of the caries completely and inspect for the carious exposure. If there is minimal exposure of the pulp with the controlled bleeding, you should check the vitality and check for the fresh bleeding, followed by the placement of calcium hydroxide, preferably dical, over the exposed area, and dry the dical with the cotton pellet. After drying the dical or calcium hydroxide, you should clean the cavity with the saline. Then the cavity is restored with the interim restoration, and patient should be reported after 6 to 8 weeks, and after the second visit, if the patient is symptom free, the interim restorative material is excavated from the cavity and the permanent restoration is placed. If the patient is symptomatic even after the 6 to 8 weeks of time, the next procedure is pulpotomy or pulpectomy is indicated. Coming to the indirect pulp capping. Indirect pulp capping procedure is similar to that of direct pulp capping, but the only difference is whereas in the direct pulp capping, the medicament is placed over directly exposed pulp, whereas in the indirect pulp capping, some amount of caries is intentionally left in the cavity such that there may be chances of reparative dentin formation to avoid the exposure of the pulp. So some amount of caries is left in the cavity, over that the medicament is placed and the indirect pulp capping method is carried out. So the procedure is, after the caries excavation, some amount of secondary caries, some amount of infected caries is affected caries is left in the cavity, and over that medicament is placed such as dical, and over that base is applied and the interim restorative material is placed, and after the 6 to 8 weeks, if the patient is asymptomatic, definitive restoration is carried out. Coming to the indications of indirect pulp capping, first one, deep carious lesion near the pulp tissue but not involving it. So the caries is nearer to the pulp but there is no exposure of the pulp. And the next one is no mobility of the tooth. So the tooth should not have any periodontal issues, so that there is no mobility, and also no history of previous pain or tenderness to percussion, and no radiographic evidence of pulpal pathology. Preoperative pulpal pathology in the radiograph should not be there. and also no root resorption or radicular diseases, which can be shown in the radiograph. Coming to the clinical procedure, as already mentioned, it is similar to that of direct pulp capping. So here in indirect pulp capping, some amount of remaining caries is left. Over that, calcium hydroxide liner is applied, followed by base and the interim restoration, and after that 6 to 8 weeks definitive restoration is planned if the patient is asymptomatic. Coming to the factors that affects the success of pulp capping, either the indirect pulp capping or direct pulp capping, there are some factors which affects the success rate of these procedures. The first one is age of the patient. As age of the patient increases, there will be constriction of the pulp chamber and the vascularity of the pulp is also decreased. So in the young individuals, these procedures are successful because of the more vascularity. And the next one is type of exposure. As already mentioned in the previous slides, if the exposure of the pulp is due to iatrogenic causes or trauma, there is more chance of success of direct pulp capping or indirect pulp capping. If there is carious exposure, there will be less chances of success rate. Coming to the size of the exposure, if the size of the exposure is pinpoint and the minimal bleeding at the site of exposure, there will be more success, whereas if there is wider exposure with uncontrolled bleeding or preoperative spontaneous pain, there will be less success rate of direct pulp capping or indirect pulp capping. So history of the pain also plays a major role in the success of these treatments. If there is previous pain before the treatment procedure, there will be less chances of success. So coming to the materials used for the pulp protection, coming to the conventional materials, the most commonly used conventional materials are varnish, liners, bases and sealers. Coming to the varnish, it is an organic copal or resin gum suspended in solutions of ether or chloroform. Whenever varnish is applied into the cavity, it evaporates and forms a protective layer into the cavity which protects the pulp from the various irritants. So indications of the varnish, the first and foremost indication of varnish is to seal the dentinal tubules. If you don't seal the dentinal tubules immediately after the cavity preparation, there may be chances of marginal leakage and dentinal hypersensitivity to the patient. And the second one is to prevent the discoloration of the tooth. Especially when you are doing the amalgam restoration, there may be chances of leaching out of mercury ions into the dentinal tubules, causing the discoloration of the tooth. So if you don't apply the varnish and do the amalgam restoration, there may be chances of discoloration of the tooth. So to prevent the discoloration, varnish is applied before the placement of amalgam into the cavity. And also protects the tooth from chemical irritants from cements, which reduces the post-operative pain as mentioned, and reduces the micro leakage around the restorations, which prevents the secondary caries food lodgement, preventing the secondary caries. So coming to the contraindications of the varnish, varnish should never be used with the glass ionomer cements because it interferes with the bonding of this glass ionomer restoration to the tooth. So you should never use the varnish when you are doing the glass ionomer restoration. And also with the composite resins, because it dissolves in the monomer of the resin, interfering with the polymerization of the resin, which causes the polymerization shrinkage or improper polymerization, leading to the decreased strength of composite or bonding of the restoration to the tooth surface. So coming to the liners, these liners are classified as thin liners and thick liners. Thin liners are again classified into solution liners and suspension liners. If the solution liners, the film thickness is 1 to 50 micrometers, it is thin film liners, and varnish is about 2 to 5 micrometers thickness, and suspension liners like zinc oxide eugenol and calcium hydroxide, it is about 20 to 25 micrometers film thickness. And also the thick film liners, the liners which is having the film thickness between 200 to 1000 micrometers. The most commonly used thick film liners is your GIC. These are the types of liners like zinc oxide eugenol, calcium hydroxide, flowable composites and glass ionomers. Your conventional glass ionomer cement and resin modified glass ionomer cements can be used as liners. So coming to the calcium hydroxide liners, this is the most commonly used gold standard liner for the pulp protection. Why it is used? Because it is having the ability of dentin demineralization by activating the enzyme ATPase from the saliva, which has the ability to form the tertiary dentin or reparative dentin. And also it is very biocompatible and high pH. The pH of the calcium hydroxide is about 12.5, which neutralizes the acidity of the silicate and zinc phosphate cements. And coming to the disadvantages of the calcium hydroxide, it has low strength and it is readily dissolvable in the oral fluids, which causes the dissolution over a period of time if there is no proper occlusal coverage. Coming to the bases, these are also the pulp protection agents. Coming to the classification of the bases, there are classified into protective bases, sedative bases and insulating bases. Coming to the protective bases, these protect the pulp from the various pulpal irritants that are mentioned earlier. And coming to the sedative bases, they have certain amount of medicaments in the bases which calms down the pulpal irritation caused by the various irritants. And also the thermal bases which protects the pulp from the thermal irritants. And these are the various materials that are used as bases, that is zinc oxide eugenol, zinc phosphate, glass ionomer cement and polycarboxylate cement, and these are the advantages. Coming to the glass ionomer cement, the advantages are it is anti-karyogenic and it has fluoride releasing capacity which prevents the secondary caries. Whereas for the zinc oxide eugenol, it has the excellent sealing ability, and zinc phosphate cement reduces the thermal conductivity of a metallic restoration, that is amalgam restorations or cast metal restorations. Whereas polycarboxylate cement also have the anti-karyogenic potential because of the fluoride content, and it also chemically bond to the tooth and well tolerated by the pulp. So glass ionomer cement and polycarboxylate cement chemically bonds to the tooth. So coming to the pulpal protection according to the depth of the cavity, that is remaining dentin thickness. As already mentioned, the remaining dentin thickness play a role in the pulpal irritation. If the remaining dentin thickness is more, there will be lesser pulpal irritation, and if it is less, there will be more pulpal irritation. Coming to the amalgam, first one is amalgam. If the remaining dentin thickness is more, that is the cavity is shallow, that is the remaining dentin thickness is more than 2 mm, varnish is sufficient for the pulpal protection. And if the cavity is moderately deep, we have to apply a base followed by the varnish and the amalgam restoration. Whereas if the cavity is very deep, we have to place the liner followed by the base and the restoration. Coming to the next cement, that is glass ionomer cement. For the glass ionomer cement, if there is cavity is moderately deep or shallow, that is remaining dentin thickness greater than 2 mm or between 0.5 to 2 mm, there is no need of pulpal protection, as glass ionomer cement has anti-karyogenic property and fluoride release. There is no need of pulpal protection. Whereas if the cavity is deep, again the calcium hydroxide is used as a liner, or that glass ionomer cement is used as a restorative material. Coming to the composite resins, if the cavity is shallow, dentin bonding agent is sufficient for the pulp protection. If the cavity is moderately deep, GICs can be applied as a base and followed by the dentin bonding agent and the restoration. If the cavity is deep, calcium hydroxide can be used as a liner followed by the glass ionomer as a base followed by the composite restorations. Whereas in the cast metal restoration, in case of shallow, there is no pulpal protection is needed, whereas in moderately deep cavities, base can be applied, and in deep cavities, calcium hydroxide liner followed by the base and the metallic restoration. So these are the various conventional methods used for the pulp protection. Coming to the recent materials that is available for the pulpal protection are, first one is MTA. MTA, it refers to mineral trioxide aggregate. It can be used as a pulp protection agent. It is superior to that of calcium hydroxide. So it is composed of tricalcium silicate, tricalcium aluminate, tricalcium oxide and silicate oxide. Why it is superior to calcium hydroxide? Because it promotes the rapid cell growth in vitro studies and maintains the integrity of the pulp. That is, it has high pH compared to the calcium hydroxide, which maintains the vitality of the pulp, and also thicker and rapidly formed dentin bridge compared to the calcium hydroxide, and have less hyperemia on the pulp and lower level of pulpal necrosis. This is the factors why the mineral trioxide aggregate is superior to that of calcium hydroxide. So coming to the recent methods, that is lasers in pulp capping. So in case of indirect pulp capping and direct pulp capping, the exposed sites can be treated with the lasers such as erbium mag lasers and carbon dioxide lasers before the placement of the medicament or liners to improve the success rate of pulp capping. So this picture depicts the pulpal exposure during the cavity preparation. There is minute pulpal exposure and the caries is removed and the exposed site is treated with the laser, either erbium mag laser or carbon dioxide laser, which causes the stasis or coagulation of the capillaries and leukocytes, and fibroblasts will be migrated to that location. So after that there will be placement of calcium hydroxide as a liner, followed by the base and the restoration, which reverses the hyperemia, and over a period of time there will be almost normal pulp. This is the indirect pulp capping and direct pulp capping. Over the indirect pulp capping, the region which is nearer to the pulp is treated with the laser, and here the exposed site of the pulp is treated with the laser, which causes the coagulation and increases the success rate of direct or indirect pulp capping. So with this it can be concluded that everyone should have a sound knowledge on the pulpal protection and various techniques and materials used for the pulp protection to maintain the vitality of the pulp. These are the references. Thank you.